Good evening and welcome to this week's Tomorrow's Podiatry podcast, where we focus on surgery with myself, Bryony Jefferies. I'm an MSc student and I'm joined, as always, by the lovely Mr. Ian Reilly, consultant podiatric surgeon. How are you doing, Ian? It's nice to see you.
Thank you. Good. Yeah, a long day today. We've been doing a bit of COVID catch-up, so one day off in February and 2 days off in March. It's been a bit busy.
Oh,
and I include Saturdays and Sundays in that. Literally 1 day off in February, 2 days off in March. So yeah, looking forward to a couple of days off over late May.
Yeah, I don't blame you. You haven't developed a twitch yet or anything?
No, not probably developing a twitch. Probably not such a good thing in a surgeon, but you know,
definitely not. Well, Ian has very kindly prepared a fabulous PowerPoint for us this evening, based around our topic of incisional nail surgery. So this is interactive, as always. We welcome your questions, everybody. Please post them in the comments box. Don't be shy. We'll do our best to get through as many as possible further on in the evening. So that being said, shall we get stuck in?
Right, so let me see if I'm following Mike's commands. So has that come up at your side then, Brian? Are you seeing the presentation?
Yeah, very good.
Cool. Don't go quiet me, Bryony, because then I just think I'm speaking to myself in my bedroom and it all looks a little bit like there's actually not 3 million people in the Twitter sphere watching as we think. So Brian and I, we talked a little bit about topics that we could do this time, and it's a real passion of mine, actually, is trying to develop different techniques around nail surgery, and incisional nail techniques is one of those things. So this is a few slides. I'm actually going to be presenting a fuller version of this to the Canadian podiatrist next month. So you get a bit of a sneak peek really on this. And I did something similar for the surgery conference last month. So we'll talk about, Brian, how long do you want? Do you think 20 minutes, something like that, 25 minutes, and we'll kind of talk around it and see what questions we get? Is that okay for you?
Yeah, that's fine for me. That works for me.
You're in charge, don't forget. I'm just the hired gun. So we've got a quote from, so this is from ECOF. So ECOF is the Cochrane review from 2000, I want to say 2015. Thinks about when I wrote this, so I think it's 2015. Obviously Cochrane is kind of the go-to meta-analysis review of reviews, and what they say is that there are really two fundamentally different approaches for how we'll address nail surgery. If you take the fact that there are conservative approaches to nail surgery and surgical, and all the conservative would be things like advanced podiatry and maybe gutter methods and nail care. So we move all of that to one side and we say, well, we've done as much as we can conservatively. We now want to do something surgically. So we can consider that we have a wide nail plate, wide nail in relation to perhaps a narrow nail bed, and we think there's a fault with that, and we seek to address that in some way, either by a P&A, partial nail avulsion, or a total, or a Winograd, or some form of excisional technique. Or we can say that the soft tissue is at fault and that we need to do something with the soft tissue. And you look at the research, which I've been looking at quite closely over the last few years. I've done some low-level articles on it. The absolute massive focus is on saying the nail is the bad guy. And we're really all taught an ingrown toenail is when the nail grows into the skin. And while that's true, sometimes it's not really the nail's fault. Sometimes the nail itself is normal and the skin's kind of in the way. Now, what the Cochrane review looked at was kind of level 1 data. So it's looking to take randomized controlled trials and high level data and pool those together. So it misses out a lot of the level 2, 3, 4s and 5s, particularly saying, hey, do you know, I've done 10 cases and here's this short cohort series of 10 cases that did really well with this different technique. So it misses those by definition, which is a shame. So the higher end research is all towards phenol. And when you look at all the techniques, phenol with a little bit of incisional comes out as the best technique. And technically that's a technique called the Aisha and Tanner, which probably most people have never even heard of, but it's actually a PA and a Winograd combination. So let's take a case. This is actually a guy he actually presented with, if you look carefully in his interdigital space 1-2, he actually presented with a dermatofibroma from a flea bite. So I actually took that out from surgically. But it was a really nice example of a wide nail. Now, clearly he's not got an ingrown toenail, but if he did, you can look at that nail and say, do you know what, that nail plate is somewhat wide for that particular toe. And if you had a cryptosis on that digit, you would absolutely say phenol partial nail avulsion would be the best technique, and I'd be completely in agreement with you. And we say very much in UK podiatry that we are experts at nail surgery, and we are very good at the phenol technique, but I will contend that we're missing the trick. There are other techniques out there that we don't do regularly or at all, and for certain indications the phenol, I would suggest, is not the best technique. So phenol alcohol, great technique, but it has its limitations. So this was on Facebook about 6 weeks ago. This is shared with the consent of Jo, who was the poster, and she put a post up. I've moved the blurb out, but she basically said, I had this guy, he's 15 years old. I did nail surgery on him last year and did a bilateral PNA. The medial side was okay, and the lateral side, it's never really settled down, and I've used silver nitrate on it. That's the black discoloration on the nail. And what you can see is you've got a fairly chronic hypergranulation tissue. So, Bryony, question to you, putting you on the spot now. This patient turns up to you. You've done nail surgery on this guy 6-8 months ago, and this is what he looks like down the road. What are you going to do with this toe?
I thought we were friends.
We were never friends, Bryony. We were colleagues at agencies. We've never actually even met.
This is true. Well, I think that hypergran tissue could do with chopping off quite plainly.
So would you feel confident in doing that?
One of that size, yes, I think I would.
Good
I've
for you.
done in personal experience. I've only graduated in July last year, so I've not done a great deal, but in the ones that I have, the nail surgeries I have performed with, there's been hypergranulation tissue. I have taken it off.
Mm-hmm.
Not had any problems, which is good.
So it's something that, I obviously trained back in the 80s. Crumbs, I qualified in 88, so a long time ago. That's 31 years ago this year. And we were certainly not taught to take this off. And I know a few guys do. Some people will hit it quite hard with the Spencer wells and do a little bit of chomping, but few pods will reach for the blade and actually take that out sharply. And so I probably see a post similar to this probably about every week, every 2 weeks. And I think this is a common presentation that we have in Podland. This is kind of how easy it is, really. So I don't know if that's gonna loop, but literally, there you go. That's an 11-second clip. So this was a case we did 3 years ago, just because I found the videos a couple of weeks ago. And so I've been using that particular set of videos as part of one of my YouTube things I'm putting together. So there's a young guy, he's about mid-20s, and he had a both first bilateral. If you look top left, you can see these 4 nail sections. So we've done left and right bilateral PNA, and then this is my colleague, and we just do this routinely. I think I was on the camera for this one. Sharply, elliptically take out that hypergranulation tissue, and I've got a 45-second video clip of the other side, but I think I'll save that for either YouTube or one of my other presentations. But you can see it's really quite quick to do. So this has been, you probably saw, because we did the Podiatry in 3 minutes, didn't we, last month now? So Nicola and I, we wrote this up last month. So there's been an area of interest of mine for a long time. So we looked at the research and we actually found there was very little written about it. Quite a few papers saying, hey, you can cut the hypergranulation tissue off, but very, very little that's done prospective. Really only found one good Korean paper. So I'm in discussion, and I mentioned it when we did the Podiatry in 3 minutes last month, that I'm hoping to run this as a prospective study with the University of Northampton. We've got our second meeting about it next Wednesday to see whether we can actually run this and do something prospective. So take a cohort of patients, I don't know, 50, 100 patients, whatever, and cut the hypergran off some and not the other, and see how they go. So from that paper, these are some of the cases that we'll talk about. So, but if we're thinking about soft tissue procedures, you've really got 4 options. You've got something you can do with the soft tissue. You can use soft tissue techniques on their own without addressing the nail. You could do a partial or a total incisional procedure, or you can even do something amputational. I've had to do a few of those as well. This was a case, this is another one of the videos I'm working on at the moment, just when I get 5 minutes. This was a guy who'd had nail surgery 10 years ago. He'd had a left first medial P&A, and you can see he's had some regrowth. So I did a mini Winograd on that. So again, keep an eye on my YouTube channel. That'll be up in probably a couple of weeks. But there's different levels of incisional techniques that we can do. So I'd use these pictures from the article. This was a case that had been presented. This is quite an old picture now. This is a previous total nail avulsion and had gone well in itself. There's probably some fungally skin knocking about, but this was a kind of a chronic hypergranulation tissue. So it kind of came through to me, and that hypergran just never settled down in the lateral sulcus. We are taught that it will resolve when the nail is gone. Some of us are taught to use silver nitrate. Spoiler alert, doesn't work. It's astringent. It's crap. Hate silver nitrate. Please don't use it. Phenol will probably do it a little bit, but you're probably better off doing sharp techniques. If you get them early, they will resolve fairly well. But when they become chronic and organized and fibrotic, those things are going nowhere, a bit like my career. So that was one case, and I think that those are in the article that Nicola and I did. Here's another one. I've used this a couple of times now. This is a Jamaican lady who diabetic and had, think how to phrase this, not being put forward for nail surgery because there was a knee replacement, there was some uncontrolled diabetes, and her pods were a little hesitant to take that on, understandably. That's in no way of criticism. But by the time it came to me, it came as, a big hypergran, and then, I've got to do something. So we addressed this in clinic, and literally, we put a tourniquet on, gave her a digital block. You can see there's a little bleb of blood at the bottom of the toe. And we cut the nail back and just cut the hypergran off, and then these just settle down. So takes 5-10 minutes to do. This again was from the article. This was probably the worst ingrown toenail I've seen. This is Doris. This is one of my YouTube vids, and again had been vigilantly managed by my local podiatry colleagues, but just with a patient with lots going on medically, and just the nail, you can see top left, it just disappeared. She'd had a TNA without phenolization, so it had grown back, and it just carried on getting ingrown and very much hypergran, very organized, lymphedema going on, all kinds of other medical things on long-term antibiotics. And you can see why that wouldn't be your ideal patient to use phenol on. So eventually came through to me after about 18 months. And so did a total nail avulsion. You can probably see, I'm pointing at the screen. You can't see where I'm pointing, but at the bottom left, there's a spike. Quite a wide nail plate for the amount, but really the nail's not too bad. There's a little spike in there, but the problem there, if I just go back up a slide, Bryony, the problem there is a soft tissue. So you could do a total nail avulsion with phenol, and that's fine, but those little kidney-shaped things on either side are the soft tissue that I took out. And she took 4 months to heal, so she was slow, but she did eventually get there, and then she was super happy, did really well. And as I say, I think kind of YouTube's a nice way of I put some of my latest thoughts and I get some interaction. So I've got by the look of things, I've got the same video up twice on that. So I've got from my YouTube site 6 different playlists. I've got one on nails. It looks like I put the same video up twice there. I'll have to check that later on. And I'm starting to flesh out with some of my incisional techniques as well. So Doris, the previous lady, she's up. That video is about 18 months old or so now.
I think I've watched almost every video you've got on there. They are very good.
Well,
do take a look.
And saddened that you don't have more to do in your life, but that's very good. Once you get married, it'll all change. So doing the research, and my one of my colleagues, who also after hours is also my wife, is doing her master's on incisional nail techniques, and she's really looked at a lot of the details. So this is some of the papers that she's been finding, and so we've been kind of talking about this for the last 9 months. She's been doing a dissertation. So this is kind of one of Andrea's finds. So 1971, Bose just looking to say, do you know what? You can actually just cut the tissue away, which effectively is what I did in some of those earlier pictures. Again, another one from the article. And this was a guy, 18 years old, son of a local GP. So I knew the GP really well. He was moderately embarrassed his son turned up like this, and the son refused to let me take the hypergranulation tissue off. So despite my best efforts, so he had a bilateral PNA with phenol, and he came back about, I think it's about 6 months later, and the lateral sulcus had completely settled down. You can see it looks like the nails off at a bit of jaunty angle, but that's just because it hadn't been cut. But you can see the medial sulcus had not settled down at all, and he just kind of pitched up, slightly embarrassing 6 months later, and said, "Yep, Ian, I should have let you cut the whole thing off, shouldn't I?" And I kind of said, "Yeah, you know." And then again, just sharply resected that hypergran, and that was fine. These do bleed a little bit afterwards, but really not too bad. So different patient. I think this is, again, one of the ones I'd use for my article. But if you imagine, I'm just going to go back a slide, a case that looks like this, okay? This was it's a different case, but this is what one of these toes looked like 3 weeks later. So this is after a bilateral partial nail avulsion. I phenolized down the side and cut the hypergranulation tissue away. That's 3 weeks after. I mean, I think that looks pretty jolly good. And my strong contention would be that resecting the hypergram, particularly when it's organized and fibrotic, will improve healing time and the overall cosmetic result. And it will certainly, with the organized tissues, when they never really shrink, it'll save you having to do anything more kind of sharply from that as a kind of a secondary procedure. And I think it's something that we, as a profession UK-wise, don't do enough. So that's really just looking at the hypergran, really almost on its own as a subsection. So we'll talk a little bit more about some of the other incisional techniques. So one of the options, and it's quite difficult to get an actual name for this, but I think Perichetti is probably the closest. This technique is linked in a couple of different articles, but rarely by name. And there are different ways of doing, effectively, a fusiform, an elliptical excision of tissues. And effectively, what you're looking to do is to take away that medial sulcus away from the nail. So here's a technique. You're not even touching the nail. You're literally just taking the skin away. So as opposed to taking the hypergranulation in the side away, you're actually taking away almost like normal tissue. So subtle options on a theme from Andrea's work that hopefully she'll submit fairly soon for her masters, and then hopefully I'm hoping she'll publish that. She's got 25 different authors who've written about different soft tissue techniques. So there's a lot of work being done out there. We're just not aware of it. So another paper that Andrea found, this is Noel. And interestingly, most of there's only, of those 25 articles, only one is done by a podiatrist. And that's an American podiatrist, mostly in dermatology, with a big flavor of it coming from South America, interestingly. So this is again another option of doing resection of the soft tissue without actually addressing the nail, and basically doing a big pizza pie wedge out and bringing it together again. So it's similar to the Perichetti, but more aggressive. This was interesting. So this had been written up by Howard way back in the day. That's the paper top left. I mean, that's like 100 years old, that paper. And then written up again by Dubois in 74, before the advent of the internet. So didn't realize the technique had been written up exactly the same. So it's technically known as the Howard Dubois now. And effectively he's taking a big apical ellipse to bring that skin down on the end of the toe to take the skin away from the nail. So this would be where you've got kind of a short, stubby little toenail, which you think, well, again, the nail's not at fault. It's the soft tissue that's at fault. And there are even more aggressive versions of that. So the next one would be something called the Super U, which was developed in Brazil by a dermatologist. And then the most aggressive of the soft tissue techniques is the Van den Bos. So this is written up by Van den Bos and Blowers. Blowers or Blowers? Blowers, probably. 1959. Written up in Canadian soldiers, actually. And they had complete cure rate. And again, not even addressing the nail, literally just chopping away that skin. And that's pretty aggressive. But this is what I'm doing for some of my cases now, where I think the nail's not the bad guy. It's really all about the soft tissue. So somewhere between the Bose, B-O-S-E, and the Van den Bos, taking away the tissues. And it basically depends how aggressive you are. So it's, again, it's a little bit perhaps not what we're used to doing. So thinking about how we break nail surgery down incisional wise into soft tissue, partial, total, and amputational, that's just really within the soft tissue parameter. You've got all sorts of options to basically say, let's take away some of that tissue, plus or minus hypergram. Does that kind of make sense, Bryony? I'm kind of whizzing through it, and I get a bit nerdy about it because I love it. Does that make sense?
It does. Yeah.
Okay. You're just being polite. Thank you for that.
If I'm following, I'm sure everyone else is following.
You're way too much. So that's really kind of soft tissue techniques. Now you can do soft tissue and combine it with nail as well, and there's kind of another range of techniques. But when we think about incisional techniques, certainly within the pod surgery world, we think really about two main techniques for partial and for total techniques. So Winograd would be your go-to partial incisional technique. Was developed in 1929, and in fact what we do now is not the original Winograd, but there are lots of different techniques. There's McMurray, there's Frost, there's a Supan number 2, lots of different partial techniques, but really Winograd's the one that only ever people talk about for partial, and Zadig is the one that people talk about for total. So the Winograd, not as it originally is, but as everybody understands it now to be, is again kind of like a pizza pie wedge shape of nail. So when you're doing the nail, you do cut all the way through the nail, and then you take a blade and you go through that nail cut down to bone, and then take a semi-elliptical section out. So I've got some pictures coming up, see if that makes sense. Why do we like the Winograd? Well, they heal a little bit quicker, so quicker than a phenol technique, which might be an advantage if you have an immunocompromised patient. If they heal primarily, you're less likely to get an infection. So it's therefore potentially useful in the high-risk patient. So here's a case that I had, and the old picture, these are about 15 years old now, these particular pictures. So I can't remember why I wanted to do a Winograd for this case. They'd obviously had something going on with the side of the nail. So your first cut would be with a thwaite and then down to bone, and then you take out your wedge. So let's do some pictures. So old pictures, I need to probably do some better pictures now. So there's your prep with a tourniquet on. So the first thing I've done is with a thwaite, and I've not got a picture of this, is cut all the way through as you would do for a normal P&A, and then take a 15 blade, go somewhat proximally, so you're going to capture all the way down to bone, proximal to the matrix, and then follow that through, go all the way through the nail bed to the bone, and exit just out of the end of the toe. A bit of a closer view. Can you see where that's going, Bryony? That's going all the way through the nail bed, down to bone.
Yeah.
Okay. And then you do a second incision, and that needs to be sufficiently proximal, so you're going to get all the nail root. If you don't go far enough proximally and far enough laterally, that's where you leave little bits in. You end up with those spiculectomies. And you're going to come all the way around, and then a section comes out of nail root, and the quite often hypertrophic nail lip. So it's a great technique if you've actually got quite a thick lateral sulcus or medial sulcus, obviously, or if you've got a subungual, exostosis that you want to take out concurrently. But it requires just a slightly different skill set. So then you'll take a little curette, Vulcan curette, because you need to scrape away any potential nail root cells from the bone. So you're quite aggressive. So that's scraping anything that looks like it might be a little smidge of matrix, and then suture. So you're suturing proximal to the nail, through the nail, and distal to the nail. So that ends up looking like that. Fantastic suturing there, I think you'll agree. And
Excellent.
sutures come out at week to 10, no correction, 10 days, 14 days. They're a little bit more sore than a phenol technique, but they heal quicker. So it's, it's dealer's choice really, but it's a good technique for the right person.
Swings and roundabouts with that.
Yeah, always.
Definitely.
So this is one of my cases. This was a young lady of about 23, 24 who'd had 2 previous phenol techniques. They weren't mine, but I've certainly had my share of failures. And since we've been using the easy swabs, my own experiences, I've been getting more recurrences. I'm not the fan of the easy swabs, but I'm not able to use 100% phenol in the places I work. But this lady had 2 previous phenols, failed both times. So I said, well, do you know what? Let's try something different. So that's 3 weeks post Winograd on previous P&As. And, she was super pleased, and she had a time frame as well. She kind of wanted to be better for a holiday. So again, you've got a slightly more predictable wound, but that looks nice and cosmetically.
Fab results for 3 weeks, aren't they?
Yeah, it was really
when you think of what a phenolized toe would look like.
Yeah, and that looked quite a mess as well. And you often develop this kind of chronic inflamed, contaminated paronychia that's going on. So, and then you add phenol. I mean, I found some of mine look really quite inflamed for 4, 6, 8 weeks, whereas after 3 weeks, she healed, and she was really pleased with that. And cosmetically as well, looked a lot better because she had a big chunk of lip on the side. So those are kind of, Winograd would be kind of my go-to partial incisional technique. And then Zadig is the famous total nail avulsion. And effectively what it is, you take the nail off, you do a H-shaped incision, fold everything back, and then you physically cut out the root and sew it back. This is from Dockery and Crawford. Now, I'm sure I've mentioned Doc and Mary before. They happen to be my godparents. They are just the most impressive people. If you've not come across any of their work, then you should have done, because they've just done so much. Incredibly skillful surgeons. Mary particularly, I did some surgery with her in Mexico about 10 years ago. Oh my God, what amazing hands. And she's quite small and diminutive. Amazing people. They've done so much for the profession, US based. Anyway, they've got they're kind of leaders in skin surgery. And that's from their 2006 edition of their book. It's actually, they've got a second edition now, which I think is 212, 213, which is excellent. So if you've got any interest in skin surgery, that is the book to buy for the feet. And of course, them being family, they let me use their pictures. And the Zadig is tricky. So when you look at the papers, the success rate of the Zadig is between 60 and 80%. Well, that's a lot less than we think with phenol. My particular technique that I use is a Fowler technique, which rather than a H is basically 3 sides of a square. So I'll do 1 incision, 2 incision, go across on top of the proximal nail fold, reflect that skin flap, and then it reflects the matrix. And then I take out an oblong section of matrix all the way down to bone. Again, I'm using a little curette, and then I've got a much smaller flap to close. And I find that they are an easier incision, as effective, and heal a bit quicker because it's not as much trauma. That's quite a nice one actually, but it looks quite pretty. And I've been using that one for about 10 years. Yeah, maybe a little longer. So looks at time. Yep, I said about 25 minutes. So that's just kind of a whiz through on just talking about some of the options for incisional techniques. And I could quite easily have talked for 3 hours. And it's stuff that we don't know about, do enough in podiatry land, because we'll say, hey, we're great at nail surgery. Yes, we are. Hey, we do the phenol technique, which is brilliant. Yes, it is. But there's more to it than that.
Yeah.
Let me close that down.
We've got a couple of comments, mostly for you, Ian. So we've got one from Rob Menzies.
Do you know Rob? Bryony? Do you know Rob?
I don't know Rob. I think I've seen Rob's name crop up on a few
from time to time. Yeah, buddy of mine. So he's Scottish. He lives out in Qatar now, and he is super clever guy and genuinely impressive on diabetes. His medical knowledge and medical management. He gets really involved with some high-end diabetic stuff out in Qatar. Very impressive guys, Rob. Rob, I hope you're not listening to this. And Robert, you left me a message about an hour ago. I'm not going to play it live on Facebook now, but I'll listen to it after this. What are my thoughts on doing X-ray on some of those nails, particularly those with involuted pincered nails, to rule out exostosis? Not pincer nails, Rob. I think you can look at a nail and have a pretty good guess as whether there's an exostosis involved there. Bear in mind the exostosis will often be an osteochondroma, so a bit of bone, a bit of cartilage, and the cartilage will be radiolucent, will be see-through on an X-ray. So it's not a bad thing to consider it, but 9 times out of 10, if you think you've got an exostosis, you'll be able to kind of see it. Pincer nails, not so much. Those are ones I think that do well, to be fair, with a phenol technique, phenol TNA. Does that answer that question, do you think, Nick? Oh, sorry, I was looking at Nicola Burt. I was looking at
I think so. Yeah. Yeah, we've got a question from Nicola as well, your co-author, on that paper that you
would you say the Howard Dubois technique could be used by general pods as an alternative to the TNA? So the answer, Nick, is yes, it absolutely could. And that's kind of one of the techniques I think that we could do. I think techniques like that where you're doing incisionals require you to have kind of extra training. It's not for me to speak for the professional bodies in terms of what they want you to have in terms of techniques and insurance and skills and training. I would suggest, because it's funny enough, I was speaking to the college today about the skin and nail surgery course that Belinda and I have been developing for them over the last year or so. That's just been delayed very much because of COVID, but we're nearly there now. So I would say that techniques like that would be within our remit, Nicola, but you'd need to have a good training process, because if you're doing techniques that are down to bone, you need to suture, you need to manage the complications. I think it's a little bit more than watch my YouTube videos and start. I can't say I've done many Howard Duboises, or whatever the plural of that would be, because I think the indication for those is relatively few. And if you've got kind of a short stubby nail, a toenail avulsion with phenol is an option. So the sorts of techniques that I like are the Van den Bos, the Bose, obviously Winograd, and the Fowlers. And when you look at the people who've written about incisional nail techniques, what they'll basically say is you can mix and match phenol and incisionals to get a nuanced approach for what might work better for an individual toe. Sorry, that was a big answer to say yes.
Do you can I ask a question there, Ian?
Of course. Sorry. Yeah.
Do you so when you were saying you don't tend to perform the Howard Dubois, but you perform the others?
I've not found really many toes that's indicated for. I nearly did it a few weeks ago, and in the end I managed it with phenol, but yeah, that's not one I have used yet.
How often would you say you sort of perform like a Winograds or Zadex, even the Van den Bos?
So I would say I do, and bear in mind, kind of as a jobbing pod surgeon, in theory, I shouldn't do a lot of nail surgery. That should be done by podiatry colleagues, really. But I do cases that come through with insurance where patients have got bupa, so they can use the bupa to pay me as a consultant, but they might not cover a podiatrist. So I probably do 100 nails a year, so not many really. I don't think that's many anyway. Bear in mind how many when I was training, we used to do lots of nails as part of our training, so we used to do 20 in a day when I was training with my boss.
Wow.
Yeah, because that was
a lot.
that's another story. So incisionals, I probably do about a dozen a year, because there aren't that many that really require an incisional. But in terms of cutting off hypergran, I would say I do that 4 times out of 5. So in terms of picking up the blade as part of nail surgery, I do that more often than not, by a long way.
Yeah. So with the incisional techniques then, although you're doing more of, you're doing those, would you say, so they're not suitable techniques for a general podiatrist, but when they are necessary, obviously they come through to you?
So no, I think they are suitable techniques for general podiatrists with appropriate training. But right. If you think about it as a sliding scale, and again, it's not for me to speak for the profession, but I actually think sharp resection of hypergranulation tissue is something that we should all do. And then I think when you get into the more technically tricky techniques, I think then you really do need to show that you've had some formal training, and ideally be very clear that your insurance covers you to do those techniques. So I'd suggest that at that point you look to do some form of appropriate training on that. But I think hypergranulation tissue we could all be doing tomorrow, really. Yeah.
I've got a relevant question here as well from Kira Moore. Thank you very much for your question. She says, am I being crazy? Don't they bleed a lot after incision? What if you can't suture? Are you still able to remove hypergram?
Okay, Kira. Well, we're all a little crazy, really, aren't we, Kira? So that's okay. Do they bleed a lot? Yes. The good news is everybody stops bleeding eventually. That's just true. That's just science. The even better news is if you so Tobro, if you've seen kind of any of Tobro's videos, he tends to do nail surgery, phenolize, and then cut. And I don't know why Jonathan does that, because it makes more sense to me to do the P&A, to cut, and then to phenolize. If you cauterize the hypergran it won't bleed as much. And if you put some pressure on, they stop. They don't bleed as much as you think. And then just put on a big chunky bandage.
That's my experience as well.
Absolutely, you're able to remove the hypergram. We missed a question there, Bryony. So question from Gina Rojas is, I tend to use the Frost or the Winograd matrixectomies instead of phenol alcohols. PNA is a phenol and alcohol. That's kind of what the Americans call it. And, you know, the Frost is another technique. What the Frost is, Bryony, is instead of doing a pizza pie wedge and taking everything out, you basically take a flap of the proximal nail fold, you lift it up, cut the matrix out, stick it back again. It's a bit less aggressive, but, you know, it's another technique. I just think it's a little fiddly. It's kind of what the original Winograd was, actually, from 1929. So, but it's dealer's choice. You know, if you've got more than one technique, so I think, you know, most UK pods just kind of have phenol. And so what I'd like to see is you know, more pods doing more things over time. Question from Ben. By the way, Ben's advertising for a Band 8A MSK triage pod up in Cumbria, nicest part of the country. Ben's one of the nicest guys out there. If I was 20 years younger, I'd be biting Ben's arm off to go and work with him. So have a look out for that job. What's he said? Winograd, Zadig, etc. Zadig spelt wrong, Ben. Do you foresee a future where more community-based pods have the skill set? Yeah, absolutely. Yeah. So I'll do. I mean, for a long time there was a concern whether Winograds and Zadigs could be done in a clinic as opposed to a theatre because it's down to bone. So having looked at the research and spoken to the CQC, it's a slightly grey area, but it seems it's fine. And I certainly do Winograds and Zadigs in clinic now. But even if you just take sharp resection of hypergranulation tissue as a skill set, I mean, because I get the ones that come through to me who've had PNA, like the picture we showed. They've had a PNA. I know I've got lots of pictures of PNA done really well. Hypergranulation tissue didn't settle down because it wasn't touched. And so we're just missing a trick there, guys.
Fab. Thank you. Thank you, everyone, for your questions so far. We'll give you a few minutes to pop a few more into the comment section. We've got a short video on a competition, fab competition that's running at the moment called Feet in 3. It's open to podiatry students and podiatrists. There's up to £1,000 up for grabs. So we've got a little bit more information here. Brilliant. I've got a few questions of myself, of my own, actually. With the so the things like the Van Boss, I think you've probably already gone through it. Those sorts of procedures then require suturing always. You wouldn't leave something like that to heal like through secondary intention. Or...
No, you would. Yeah. So you don't suture those. So of the techniques out there for soft tissues, some are to be sutured, some are not. Lots of them are actually healed by secondary intention, Bryony. And you look at things like the Van den Bosch. I remember coming across that about 10 years ago probably through Facebook, actually. And I'd never heard of it before. I've been doing Winograds and Zadigs for, 25, 30 years with my pod surgery training. But I looked at that and went, wow, that just looks really aggressive and barbaric. But when you look at the papers, and there've been a few papers out there on that technique, they get super impressive results. Sadly, not level 1, so they've not been included in the meta-analyses. But they heal really well, better than you'd think. They can bleed a little bit. So I've been doing quite a few of those this year as I've been trying to develop my video library. So as I've been doing them now, because I've been doing them, I've been basically saying to my patients, with consent, my views on this, we've spoken about this before, just to kind of build up a little video library for teaching purposes, really. And so I've been trying to get a few cases of before, during, and after. And certainly a few of them have bled a little bit, but it's amazing how quickly they heal and how good they look cosmetically. And better, and if you've got that chronic organized fibrous hypergranuloma, if that is a word, I think they will often need addressing.
Yeah, I've seen a few videos on YouTube. There's resources everywhere. Looking at the Vanden Bosch, and it does look aggressive. At first sort of glance, it looks really, really aggressive. But then they showed the results afterwards, and they were fab results. It's a really aesthetically pleasing toe at the end of it, and the nail is saved. Yeah, it's a better option than I think it sometimes just looks.
It's a better option than you think. Now, interestingly, because we've got a very good go-to technique, the phenol technique. Excuse me, Bryony. If you speak to podiatrists in countries where they don't have access to local anaesthetics, and they're quite jealous of us for that, some of our European colleagues particularly, so they need to do a lot more with conservative management, and they'll use nail braces. There's some interesting evidence for nail braces. Orthonixia, I think, will be the technical term. But they'll also talk about the downsides of phenol techniques and Winograd techniques, where they see patients who are really upset by the cosmetic look of having, little stubby bits of nail left. If somebody's done an overly aggressive, like a bilateral PNA, sometimes known as the Brazilian technique. Bryony, I'm not sure if you're familiar with that. Just a little strip down the centre. I'll send you a picture in a bit. So there's a cohort of patients out there who've had a technically successful procedure. They've not got an ingrown toenail, but they're not happy with the cosmetic look of it.
Sorry, got myself on mic.
Yeah, no, I'd look and see if there's any more
on mic, on mute. Mute in the Queen's English. With the you showed a little graphic earlier of like your soft tissue approaches, your partials, your totals, and amputation.
Oh yeah, we didn't touch on that. So there are times that I've had to take off distal phalanx of a hallux for a bad ingrown toenail. So that's the Lambrinudi technique. No, it's not. It's not at all. Lapidus. I'm sorry, I'm getting my L's mixed up. So there's a Lapidus technique where you take off most of the distal phalanx, and that's very effective. And I've had to do a few of those. So I don't tend to do it for the big toe very commonly. You'll be surprised to hear, but I'll do it not uncommonly for a fifth toe. So if you've got a really crappy dystrophic fifth toe, then sometimes doing a terminal cyme, as we'd call it, on a fifth toe is an acceptable option, particularly if you've got almost like a long fifth toe with a really bad Delaca's corn.
Yeah. We've got another question from Nicola Bear. Thank you. As we are aware, the ideal would be to send the hypergram tissue to histopathology. If we don't, would we stand under scrutiny legally? Could we get pulled up under any medical legal stance for not sending them off?
The answer is yes. Good question, Nicholas. It's one of the things we addressed in our paper, and I was kind of reflected and said that I don't routinely send off my hypergram. And if you've got a really obvious ingrown toenail with hypergranulation tissue that's developed over time, if it looks like a duck and talks like a duck, then it's probably a duck. But I've seen a couple of cheeky ones, and I do send off histo things all the time. We've had a range of pathology come back that was atypical. Interestingly, I had one back yesterday. I sent off a corn that came back as a molluscum contagiosum. So the point Nicola's making really eloquently is that we should think about having access to histo. I don't do it routinely. I probably won't if it's really obvious, but there's a potential there for being pulled up if you do miss something. And I've certainly seen a few of those. So the point would be have access to histo.
Do you think that? Yeah. Do you think that could be a barrier then to perhaps private podiatrists?
Yes and no.
If they haven't got access.
As you have to kind of pick up the phone and go, "Hi, I'm one of your local pods. I'm really skilled and I've got this particular set of patients and I need access to histo. How do I go about it? Not can I have access? How do I get access?" Now it might just mean. So I had this conversation with Diane Ashcroft, Purple Potty Pod. So Diane asked me for she won't mind my name dropping her, asked for some help on a patient with a nail about a year ago, and she said it looked a little bit skew-whiff, and it sounded like it was a pyogenic granuloma more than hypergran. So I said, well, speak to your local histo guys and ask if you can send a sample. Well, telling me sending a sample. And they took it and they said, yeah, and that's fine. And they didn't even charge you for it. So that, your local histo lab will get bits from all these different surgical services and GPs. You just need to have a relationship with them. It might, if you're a private pod, there might be a cost involved. So I did 2 soft tissue excisions yesterday. One was absolutely a verruca, and the other I'm not so sure on. And I did an 8mm punch biopsy on these 2 lesions and send them off to the lab. One was NHS and the other was self-funding. So the self-funding patient, we added on £239 for the cost of histo, because in my private hospital, that's how much the patient gets charged for histo. So out of that, there's a markup for the hospital, there's a markup for the lab, and that's about 50-50 split. But I think 239 sounds a lot. It is a lot, but it's reasonable to say we know what the diagnosis absolutely is. And particularly for one of the lesions, I wasn't too sure. So we absolutely needed to have histo on that. And it's something that we should be thinking about doing. It should be routine. I can't believe more of us don't have it as a routine thing. And when Belinda and I start the skin course soon, we have a whole lecture on histo, how to get access to it, how to send, what the British standards are. But it's all very doable.
Yeah. We've got a question from Yvonne O'Flynn, who's asking, where will that course be available?
London and Northampton. So we'll probably... probably Nottingham, actually. So we'll hopefully start it this summer. Otherwise, I think I'm end up hanging up with scalpels and becoming a monk, because Belinda and I have worked so hard to pull this together. So we're literally, to have like a lecture on how to do histo, because it's the easiest thing for me in the world just to kind of send off a sample to the lab. I don't even need to think about it. But I understand if you're in private practice, you need to kind of go through all the different steps. So the course is going to be split into 6 sections. It'll be pre-reading, so directed reading, 3 days of lectures with an exam, and then a couple of days on the skin pads, learning about suturing and skin excisions. Then we'll do some cadaver work as build-up working, and then there'll be an exam on that, and then there'll be a portfolio. So it's kind of 6 sections over 6 months. So probably with pre-COVID, we were going to run it at the society offices down in London, but we'll probably run a lot of it online now, because it actually works better than we thought. And then we're not quite sure yet whether I use kind of my facilities in Northampton for some of the skin pads. We'll use a cadaver lab in Nottingham for some of the cadaver work. So we've actually got feet booked, so we can actually do Winograds and Zadix and skin excisions on real live feet, real dead feet, and to really kind of see how the tissues move. You can only do so much on pigs, trotters and pads.
That's
so
true.
Watch this space. I don't mean to come on and kind of promote the course per se. That wasn't the main effort for the evening. The main effort was to say, skin incisions is something we should think about as part of nail surgery.
Yeah, definitely. It's definitely something we should be thinking about. I've got something to promote though. The Flexitol.
That's easy for you to say.
The tomorrow's Podiatry Awards are open. Please visit tomorrowspods.com/awards.
Sorry, you use Flexitol on an open wound, Bryony? Or is it?
Only as often as I use tea tree.
Belinda might be watching this. I'll pass your email.
Absolute joke, I promise you. Absolutely not. Apologies. And apologies to anyone who has had a bit of trouble submitting an entry up until now. There was a little bit of tweaking that needed to be done, but it's all sorted. So please do go back, have a look, and see, and you can submit there. We've also got a nomination builder. So if you want to nominate someone, but you're not sure what to say, or you want to give your nominee the best chance of winning, why not try using that? It's great. So I think we've got a little video around the Tomorrow's Pods Awards. And I think that's everybody that's coming up over the...
Oh, there's Brian, there's one more question that squeaked in from Jean Rojas again. So it sounds like she's in the US. Do private companies have access to skin and nail samples? The answer is yes, there are private companies out there that do private histo, but typically what happens is it's your local NHS departments that work for the NHS will also take on samples from private practitioners, GPs, private hospitals, and do it as part of their income generation.
That's fab. Have we got... I'm not sure. Right. Are there any more questions from anybody? If you'd like to just drop them into the comment section below. We've only got a few more minutes.
And then Michael cut us off because Mike knows if there's no questions, then I'm just going to start telling jokes and Mike will come in and he'll cut me off. We were just about to do the penguin joke last time and then he went straight to adverts.
He did. It was perfectly timed.
He knows when I'm about to start being...
It was impeccably timed, to be fair to him.
How cool are the graphics, though, that Mike does for this, Bryony? I mean, are they cool?
They are brilliant, to be fair.
I think we should basically say Mike is the good-looking one behind the camera. I don't know how he does this in his spare time.
Yes, I think this is his baby. It does, yeah. This is all thanks to Mike. It really is. I've got another question then. I'm going to take the opportunity. So with the when a grad's over your standard PNA with phenolisation, what sort of recurrence rates do you find when comparing the two?
So if I say for Zadig, it's 60 to 80% for the Zadig, which is really quite low. And that's because it's a kind of it's a more difficult technique. It's really easy to miss little bits as you go laterally if you don't go lateral and proximal enough of the root. And B, it's often done by kind of like the junior members of the team because it's like, oh, you just do the nail and I'll go off and do the knee, where it's done, within orthopedics or general surgery. So it's often given to the junior member, the least skilled member, and it's actually one of the more fiddly procedures. So 60 to 80% for phenol. For Winograd, it's slightly higher. It's probably 80 to 90% overall, whereas you'd want really the phenol to be 90, 95%. So it's not as successful in terms of outcomes. So it's useful for revisionary procedure. It's useful where you've got a secondary thing to do as well, like a subungual exostosis, where you don't want to use phenol on a bone. That's not a good look. So it's useful for where you've got a very hypertrophic medial or lateral lip, or particularly useful where you want somebody to heal a bit quicker, which might be your immunosuppressed patient, or for me, a patient's like, I'm on holiday in 3 weeks' time, you want something that's going to be a quicker fix. But it's by no means my go-to procedure for nail surgery. Phenol is still my go-to because the results are better, but it'd be phenol with hypergram resection sharply.
Yeah, that's fab. Thank you. I think I've got one more question, but I've almost forgotten what it was. What were we just saying? Oh dear. I'll tell you when it's got to me. I've run out of coffee.
So we had a young kid of about 10 had an ingrown fingernail, Bryony, and he caught his finger in the car door, and he had to spend 3 weeks in hospital with it. 3 weeks, nearly died, and do you know why?
I know, it's a joke.
He was picking his nose at the time. It wouldn't have been so bad, but it just happens.
Oh dear.
I wonder actually, if you're 10 years old and you're playing peekaboo with a child and they have an accident, would they end up in the ICU?
Oh God. Right, then.
That's brand new, that joke. First time out. It's the first time I've done that joke.
That's the exclusive on Ian's new joke of the week.
Mike, it's nice and clean. You didn't need to cut me off. Nobody's been offended by that.
Well, I'm afraid the time has come anyway. You got it in, though. You got it in before we had to leave. Well, thank you, everybody, for joining us. Thank you all for your questions. Thank you, Ian. Hope you've enjoyed this evening. So we'll let everybody go now. Enjoy the rest of your evenings, everybody. Thanks, Ian.
Cheers, guys. Oh, and any suggestions for another topic, email them into Bryony or I, and we'll try and meet demand if you've got any ideas you'd like to talk to us about.
I think next time is my last one as well. So yeah,
yeah, I know. Why? What's happening? Where are you going?
Oh, I'm too old for it now, aren't I?
I didn't get the letter
you, need
of
some,
resignation.
you need some fresh meat now. You might see
Yeah, I'm
me.
getting old myself. Yeah, maybe we should both step down and get the next gen in. Anyway, any ideas, send them through.
Fab. Thank you, everybody.
Cheers, guys.